Welcome everyone once again. So I'll be giving a brief introduction about Yetena Weg and what we do, and I'll be introducing our guest speaker for today. So Yetena Weg is a network of volunteers, and it's registered in Pennsylvania, USA as non-profit and entirely run by volunteer members. As of now, we have 70 active volunteer members across different countries, and we're still growing as a network of volunteers. So our projects and engagements are mainly classified into 4 areas. So the first one is health promotion, where we have discussions and health articles of major public health issues. The second one is community engagement, where we involve in voluntary activities such as blood drive, inclusiveness, equity projects, fundraising campaigns, and so forth. The third and one of the core areas of our engagement is the mentorship and skill sharing, where we give direct mentorship for young medical professionals and medical students in various aspects, such as soft skills, career and professional development, and so forth. So we pair our mentees with highly distinguished mentors. So this is one of our projects. The final one is medical education. The continuous medical education department prepares different webinars and important public health and clinical medicine topics. So this today's webinar is also one part of this department. And other one is the research and QI projects. So these pictures show our engagements in the past. So the other is the inaugural health article writing competition, which is prepared in collaboration with the Ethiopia Medical Students Association. So currently, the fourth round of health article writing competition is organized, as I said, in collaboration with Students Association. So it was announced on September 2nd, and the Roha Medical Campus through Roha Health Foundation will award travel grants for 2 health article writing winners and other recognitions also part of this initiative. So you can see the pictures here. You can see the winners. These 2 health article competition winners were able to get travel grants to visit global health equity in Rwanda. So the other is one of the giant projects we have is the Yetena Weg Research Fellowship, which is research fellowship, which is prepared in collaboration with Addis Ababa University and St. Paul's Hospital, Millennium Medical College. It was started on March 14th. It involves 3 departments, namely oncology, radiology, and internal medicine. So it will provide research grants for up to 4 winners and mentorship for 10 winners. So these were the winners of this research and QI fellowship. Yeah, so the other is the continuous medical education. We've been preparing various important health topics as CMEs in the past, which you can find on our YouTube channel. They are freely accessible, and they are prepared in collaboration with the Ethiopian Medical Association, Ethiopian Society of Cardiac Professionals, and Ethiopian Society of Internal Medicine. So far in 2024, 30 CME webinars were held, and average webinar attendee ranged from 150 to 200. Mainly, our main participants are healthcare professionals and primary care physicians. And in 2024, we planned more than 30 webinars focusing on emergency and surgical cases, ENT, pediatrics, OB/GYN, and oncology. So we have very distinguished experts as our speakers. So you can access our previous CME sessions on our YouTube channel for free. So where to get updates about our upcoming CMEs, you can join the Yetena Weg Telegram channel for healthcare professionals. Link will be available in the chat section, or follow us on social media platforms, Twitter, and so forth. So this is very important. So based experience in this webinar, please, if you have questions, send the Q&A or the chat box. And at the end of the webinar, your questions will be addressed by our guest speaker accordingly. And to be certified, you need to pass through these 3 stages. The first one is you need to attend the whole session virtually. So we'll be cross-checking the attended minutes via Zoom. And the second step is make sure to fill the Google form and the personal details in the section, and finally get 50% or above on the post-webinar quiz. The post-webinar quiz will be shared at the end of the webinar, so you need to get more than 50% to be certified. Thank you very much. So I will now be introducing our guest speaker for today. So Dr. Dagim Leykun, subspecialist in vascular and endovascular surgery with over 10 years of experience in general surgery. He serves as an assistant professor in the Department of Surgery at our university. He has played a pivotal role in establishing vascular surgery services at Hawassa University, providing services for the broader southern part of Ethiopia. In addition to his work, Dr. Dagim also provides vascular care to hospitals and introduced Endovenous EVLAT varicose veins, the first of its kind in Ethiopia. In addition to his clinical work, Dr. Dagim is actively engaged in research and professional development, contributing to advancements in vascular surgery across the region. We're very honored to have Dr. Dagim. Dr. Dagim, thank you.
Thank you so much for the introduction. Hello, everyone. Welcome to today's webinar on varicose veins and introduction of endovenous laser ablation treatment in Ethiopia. I thank you, and I'm also very much honored for the Yetena Weg team for their collaboration and allow me to be on their platform and deliver this webinar. And I thank you all for joining this important discussion today. Just to give you some context for our just contextual overview and give you some highlights regarding today's webinar. So varicose veins are very common, yet they are often overlooked and misunderstood and inadequately managed. They are probably one of the most common conditions that general surgeons and primary care physicians see, but it has been sidelined and surprisingly it's absent from public health conversations as well. And there is also little focus in trainings. Also, we see especially in our setup, there are only very few researches regarding varicose veins in our setting as well. Part of the reason is because most physicians see it as varicose veins as aesthetic concern or cosmetic concern, but they go beyond cosmesis. There is an underlying problem, and strictly speaking, varicose veins are actually a manifestation of an underlying disease, what we call venous insufficiency. So the proper term is actually varicose, for varicose veins is venous insufficiency, but the term is very popular and most people tell you that they have varicose veins, but this also undermines its problem and most people view it as a cosmetic problem. But the reality is quite different. Untreated varicose veins can lead to very serious complications. It can result in recurrent leg ulcers, which is very difficult to manage and very difficult to heal. And it can also predispose to very life-threatening conditions like deep venous thrombosis. And sometimes this varicosities can also bleed, and it can be at times, although very rarely, can also be life-threatening. And today, I'm also going to tell you about latest treatments, advanced treatments, minimally invasive treatments like endovenous laser ablation treatment that we are introducing here. So it's a very safe and effective treatment, which is accepted globally. And I'm very much excited to say we are making this breakthrough available right here in Ethiopia, particularly in Hawassa. So this webinar is intended for primary care physicians, any person, any health professional involved directly or indirectly in the care of these patients. So attendees of this webinar, the aim of this presentation is to deepen your understanding of varicose veins, all about varicose veins, I can say, the diagnosis and the treatment options, the management options available, from simple management options to the most advanced ones. And also, I hope you will learn how endovenous treatments can transform varicose vein management in Ethiopia. And also, this purpose of this webinar is to encourage timely interventions and proactive engagements to enhance the vascular care in Ethiopia. So first, let me give you an overview of today's webinar. So I'll start with a brief introduction about varicose veins, and we'll discuss about the prevalence and incidence worldwide and in this region, as well as some available literature regarding our setup as well. Then we'll look into its impacts, also the causes and risk factors, and the underlying anatomy pathophysiology of this disease condition. We'll cover also the clinical manifestation or symptoms, and I'll walk you through also how to clinically evaluate these patients and the diagnostic tools available. Then we'll explore the treatment options, and I will give a special emphasis on EVAL treatment that we are aiming to make this treatment available here. And finally, I will wrap up with a summary followed by Q&A sessions. Introduction. So what are varicose veins? These are actually patients self-diagnose their condition as varicose veins. And when they see an enlarged, twisted, elongated, tortuous, superficially visible, which is under the skin, those are varicose veins, and they appear as dark blue or purple in appearance. And this is caused by actually a weakened vein wall or because of faulty valves. This will result in abnormal flow or abnormal return of blood from lower extremities, which can also lead to symptoms like discomfort, to other symptoms, range of symptoms. They can include, based on the size, they can include, we call this varicosities, varicose veins, when their size is larger, typically when it's greater than 3 millimeters in diameter. But there are also smaller veins that you see in this picture as well. We call telangiectasias or spider veins. And a bit larger than this one, 1 to 3 millimeters, they are called reticular veins. These are all manifestations of a disease condition because of venous insufficiency. So varicose veins means actually dilation of superficial veins in the lower extremities. When this becomes a more severe, we call it a chronic venous insufficiency. It's a condition where the blood flow back to the heart is impaired, and this severe varicose veins can lead to a condition known as chronic venous insufficiency. And it can result in further complications if it's left untreated. So why does it matter, varicose veins? As I've gave you some highlights, it's a high prevalence. It's actually very common disease, even very common than other vascular conditions that we are seeing. And it's frequently also underdiagnosed and mismanaged, considering that this is only a cosmetic problem. And untreated varicose veins can also lead to severe complications, like chronic ulcers, non-healing chronic ulcers, DVT, and bleeding, and these are some of the complications. There is also lack of awareness in patient side as well, and they delay in seeking treatment because patients also often consider this as a cosmetic problem, and they usually say, or they don't realize the severity of even their own symptoms until they experience the relief the treatments can bring. And the other thing is it's very important for this condition to be timely intervened before it causes severe complications. So when you see the impact of these varicose veins, it's a huge public health burden. It has also other, it's not only just a health issue, it can have also a significant public health with physical, economic, and psychological dimensions as well. So this public health burden can have physical and quality of life impact as well. Patients often report that because of these symptoms, they may have difficulty of, with limitation of their daily activities, with work absenteeism, even early retirement, and also job restrictions. These are some of the conditions that can affect the patient's physical and quality of life impact. In fact, around 75% of patients report physical limitations in their daily activities. It has also huge socioeconomic cost. In US alone. Treatment of these varicose vein ulcers cost around 1 billion annually, and close to 1.8 million lost work days annually, with early retirement greater than 12% of affected workers. So this has direct and indirect costs of varicose vein management. It has also impact on psychological and social effects as well. So it can impact mental health, which can lead to distress, anxiety, social withdrawal. Patients often avoid social gatherings because they feel self-conscious and avoid social activities or clothing that reveal their condition. So it has some impact on psychological dimension as well. And in some studies, around 45% of patients have mild, moderate to high psychological distress. So it has not only a cosmetic concern, it has multi-dimensional impacts on the society as well as on the individual patients. So let's go back and look at the history of varicose vein and its treatment, how its treatment and understanding developed over time. It's interesting how far we have come to this era. The earliest recording about varicose veins was in ancient Egypt in 1550 before Christ. That's the first mention. During the classical Greek period, Hippocrates, which is a father of medicine, he actually introduced compression therapy, which is still used today, and he also identified links with varicose ulcers, these varicose veins with ulcers, venous ulcers. Fast forward to Roman Empire, they tried some surgeries and treatments without anesthesia. In 15th century, that is a period of early modern medicine. Leonardo da Vinci's anatomical diagram brought some understanding about these anatomical diagrams can help to enhance our modern anatomical understanding of this, the veins, as well as the circulatory system. It is during the 17th century, actually, the term varicose veins were introduced, and they used to treat during that time with some medications through the veins, and that's also the time where early start of this sclerotherapy treatment started. When we come fast forward to modern advances, that is the 20th century, there is renewed interest in the management of these patients. There was improved diagnostic and surgical methods, and vein stripping and phlebectomy were the effective treatments that were introduced during this time. But there was little improvement during this time, and by the turn of 20th century, by the turn of 21st century, there was some introduction of less invasive treatments during the 1980s and 90s. There was introduction of these endovenous treatments, and there is what we see in the 21st century is a shift from these invasive treatment options, surgical options, to a minimally invasive methods. And there is also ongoing research and innovation, and this is pushing these advancements forward and improving patient satisfaction and health outcomes. So so understanding the history shows us how we have come this long way, and today I'm also introducing this EVLAT in Ethiopia. We are bringing these latest advancements, minimally invasive methods. So we are also contributing to this historical evolution of varicose vein management as well. So coming to the prevalence and incidence of this problem, globally, it's said around 25% of adult population. Some papers even say up to 40% of adult population is affected with this problem. It's particularly common in women and older adults. They are more susceptible, and the female to male ratio is around 3:1 range. So women, especially in their 40s, are commonly affected. And the annual incidence is also very high, and females is higher than male. This also indicates that new cases are continuing to emerge globally. When we see the US data, it's around 25 million people are affected with this condition, and around 1%, 1 to 4%, that's around 2.5 million of people are affected with complications of this condition, chronic venous insufficiency with venous stasis ulcers. So as you can see, it's a significance of varicose veins as a public health issue, and it deserves more attention than it's actually currently receives. So when we see regional data, there is varicose veins haven't been studied extensively in especially in sub-Saharan Africa and African setting. There is a huge research gap. And some studies actually show the prevalence is estimated to be lower than the Western population, but it's rising because of shift in the lifestyle, urbanization, and other factors. So there is some increment in the incidence of this disease as well in these regions. One of the few studies available, which is done in the Tanzanian study, which shows low prevalence than the Western population, and they have also shown that diet plays some role fiber diet has some protective effect, and urbanization and changing the lifestyle. These are some of the things causing a shift or increasing in the incidence of venous problems, these varicose veins. So they suggested a need for awareness and preventive measures, especially in rapidly expanding or urbanizing regions across the region. When we see, with regard to our context in Ethiopia, we face a unique challenge in managing varicose veins, and it remains also largely under-researched. There is limited data available and also limited access to these advanced treatment options like endovenous treatments. There is also lack of access, especially in rural settings. And also probably this disease also might be even more common because of our lifestyle. Most of the populations in our setting, for example, individuals in occupations that require standing for a long period of time or sitting, especially those engaged in manual labor, farming, retail, waiters, teachers, even doctors, they are at higher risk. But unfortunately, there is limited awareness also. This condition means that early detection is rare, and most patients have an advanced disease before they seek treatment. Some available data, when we see some available data with regard to varicose veins, there was some study at Blackline, Hawassa Hospital in Addis Ababa, which was pattern of vascular diseases, a 1-year prospective study. They have evaluated around 386 patients. Out of these, 100 of these patients, around 25%, or around 26% of patients were varicose vein patients. It's second most common to peripheral arterial disease. Even I think this is also an underestimation. It's the most, I suspect this might be also, varicose veins might be also the most common problems. Unfortunately, only 4 cases are treated surgically, which is 5.1% of all varicose vein cases. So this is, by most standards, this is a very low rate of intervention. Actually, most of these patients, around 70%, 80%, can be managed with conservative management and can delay treatment. However, around 20 to 30% of patients require some kind of intervention, either surgical intervention or minimally invasive treatment. So this is very low intervention. There may be several reasons for this. Maybe these patients were on conservative management, or maybe they are also waiting in the waiting list. So we don't know about the status of these patients. This also indicates there is a need for further study. The other study which I found here is regarding determinants of lower limb varicose vein, which is studied. It's a kind of case control study at Walaito University Hospital. They evaluated around 118 cases with 236 controls, and they have identified some factors which are significantly associated with varicose veins, like lifestyle factors, heavy lifting, smoking, dehydration, irregular bowel movements, and also dietary factors. Some fiber diet is a protective effect, and also identified significant risk associated with varicose veins in patients who have first-degree relatives. And they recommended for preventive strategies, which is based on identified risk factors to improve patient outcomes. So obviously, as you can see, there is very limited research in our setting as well. So this is one of the public health problems which needs further research in this area. So coming to the causes and risk factors of this disease. So the cause can be classified as primary, secondary, and congenital diseases. The primary one is because of due to a genetic weakness in the vein wall, which is due to genetics. And it's actually slowly progressive disease. It's a degenerative disorder, which is characterized by dilation of these veins, and this will result in stretching of the valves and will result in reflux. And it can involve a large segment of the veins. It has a widespread occurrence, and it tends to start usually beginning in the superficial veins, but it has a slow progress. And you can also delay treatment in these patients because it takes about a decade to progress from less severe form to a more severe disease. The secondary cause is it's an acquired one, either because of trauma to the veins or because of some events like post-thrombotic DVT events. This will result in venous valve distortion because of scarring and inflammation of these valves in the vein wall. And it can be a rapidly progressive inflammatory disease, but it involves a limited segment of the veins. And in this case, it primarily involves the deep veins, and it results in the vein valves and distortion of these vein valves and wall itself. So it may be because of a combination of factors, either obstructive and reflux. So we'll see it in the pathophysiology later on. So the other cause is congenital disease. So it means it's present at birth. It's because of abnormal development of the veins. There are certain disease conditions or syndromes which involve the veins, like Klippel-Trenaunay syndrome, which is a defective vein development, absence of the deep veins, in presence of these anomalous veins, lateral marginal vein. Or valves may also be absent congenitally or malformed. And these patients are often telltale sign is these patients may have associated anomalies, and they have also some vascular anomalies like birthmarks, these port vein stains, capillary malformation, arterial malformations, and they have also some enlargement of the limbs, which is enlarged or longer limbs. This may be associated signs which may suggest congenital cause of these varicose veins. When we come to the risk factors, so the risk factors is very important to understand. They don't appear because of these causes. There is also some risk factors that play significant role in the development of these varicose veins. The primary risk factors actually family history, genetics as a cause as well as risk factor. So it's a strong family history of venous insufficiency is a big clue. These patients likely to have families with some member of their family having varicose veins, and so this tells us that genetics plays a crucial role, and there's ongoing studies to identify specific genes which are associated with varicose veins and so on. Second, very important risk factor is female gender. It's very common in female. It's related with hormonal factors, progesterone and estrogen. These hormones are known to cause vein walls to relax. So this makes them more prone or predisposed for dilation. So this is why women have increased risk. And also, it's also seen during pregnancy as well because of increased increment in this during this period, hormones, because of other changes as well, increased blood volume, also pressure of the gravid uterus on the big veins in the abdomen, on the pelvis as well. The other very important risk factor is age. Obviously, with aging, naturally our veins lose their elasticity. These are the elastin and collagen are very important components, extracellular components that maintain the integrity or strength of a vein wall. So with aging, our vein walls lose their elasticity, and this also makes them prone for dilation. That's why it's seen more common over the age of 50 years. Obesity is another very important risk factor. This extra body fat, body weight can put extra pressure on the veins, particularly in the legs, is also an important factor. The other one, as I said, pregnancy is also an important risk factor because of the increment in hormones, estrogen, progesterone, causing vein wall dilation, as well as increased volume, which is associated with pregnancy, and compression of the major veins, which increases the pressure in the lower extremities, and this requires more efforts for the lower extremity veins to return blood to the heart. There are also some additional contributing factors like prolonged standing and sitting. There are physiologic changes that occur during standing. We'll see it later in the pathophysiology. Occupational factors which require long periods of immobility, like sitting for a long period of time. Office workers can also be affected. Sedentary lifestyle, people who have limited physical activity are also predisposed. Heavy lifting, smoking also contributes to varicose veins. History of venous thrombosis, past history of DVT can contribute also to development of these varicose veins. So let's come to some basic considerations, anatomic considerations, and anatomy and physiology. This is very important to understand the anatomy as well as the physiology of lower extremities, very essential for diagnosis and management of these conditions. This helps us to identify the locations which are very important for management as well, especially in endovascular procedures. So when we see lower extremity veins, they consist of three systems: deep venous system, superficial veins, and there are also perforating veins which are connecting these two systems. These three systems are hemodynamically connected, and the deep veins are these are the major component of the venous return. They are found deep in in our body, below the muscular fascia, very close to the bones. They usually accompany the major arteries, and they are very critical in return. Most of the blood return is through this venous system, and they are very important. The next ones are the superficial venous systems. These are veins which are found just underneath the skin. The most important ones are the saphenous venous system, the greater saphenous vein, GSV, and the lesser saphenous vein. And there are also tributaries. These tributaries, we generally call them the superficial venous system epiphyseal veins because they are found just above the muscular fascia. And they directly or through tributaries connect to the deep venous system, and actually the flow is from the superficial venous system to the deep venous system. So it's very important to see also individually this venous system, because the superficial venous system is these truncal systems are the most common veins which are affected by varicosities as well. So when we see the greater subvenous system. As you can see in the picture, the course of the greater subvenous vein, it starts from the medial malleolus, just anterior to that, and it courses, it ascends in front of the medial malleolus, then it continues along the medial edge of the tibia, then it assumes a little bit posterior position and reaching to the inner thigh and joins the deep vein at the saphenofemoral junction. So this course is usually the most common course, and it's predictable. The JSF is very predictable. It usually assumes this course. So it's very easy to identify it. Sometimes even in very thin patients, it's visibly, it can be visible, it can be seen. When we go a little bit deeper, it goes in its own compartment. We call that the venous compartment. It has its own fascia, just a superficial fascia, and just below it is the deep muscular fascia. So it's bounded by this compartment, and it's also very important. This compartment is very important for identifying the vein when we are seeing it with ultrasound. So typically we'll have a certain feature, a kind of eye sign, Egyptian eye sign, because of the two fascias and hypoechoic circular area in between. That is, and we can identify it as a greater subvenous vein. So that's how we differentiate it from other veins. So it's a bit, the anatomy is a bit different from other epiphyseal veins. The wall is a bit thicker, and as a vascular surgeon, we also like this vein very much because we use it to do a bypass procedure. It's commonly a breasted vein, and it's very good to replace the arterial system as well. This junction with the deep venous system is a special area, the saphenofemoral junction. Again, its location is very predictable. The surface landmark is just it joins the deep vein, which is found medially, which is midway between the anterior superior spine and the pubic tubercle, and midway what you feel is first the artery, then the vein is medial to that, and you can predict that it joins the deep vein around 30 degrees to the deep vein. And in majority of the patients, this area has a preterminal valve, which in majority of patients found within 1 centimeter of its junction. So this valve is very important for prevention of reflux or backflow from the deep system to the superficial venous system. So there are also other additional superficial venous structures which are connecting with the greater subvenous vein. These are also very important. It has it has surgical importance. The greater subvenous vein, its tributaries include in the thigh. There is accessory subvenous veins, the anterior, as you can see, anteriorly, in the posterior subvenous accessory subvenous veins. These are actually they usually go in the subvenous compartment in the upper, in their most proximal portion. They go with the subvenous vein, greater subvenous vein, and they usually exit this line. This dark mark is where usually it exceeds the fascia, superficial fascia, and becomes external to the superficial fascia. And it has connection this in the upper thigh, in the lower parts, what we call the anterior arch and posterior arch veins. These are also major tributaries to the greater subvenous vein, and it has also intersubvenous connections. So this accessory subvenous veins also directly communicate with the greater subvenous vein, and they all drain proximal to the usually proximal to the subvenofemoral junction. So identifying these connections is very important in truncal varicosities or insufficiency involving greater subvenous vein. Sometimes the greater subvenous vein may be missed, and you may be seeing an enlarged axillary subvenous vein, and this is also most common cause of recurrence of these varicosities. So when we see the lesser subvenous vein is another vein. Again, this is the lesser subvenous vein. The superficial landmark starts from the posterior to the lateral malleolus. It progressively assumes a median position, and it joins the deep vein at subveno-popliteal junction. So as compared to the greater subvenous vein, it has especially the junction of subveno-popliteal junction, it has some variability. In the majority of patients, it enters or joins deep vein, the popliteal vein, just as a knee crease posteriorly. However, sometimes it may join the deep vein a little bit higher up and below that, and also the pre-terminal valve at the subveno-popliteal junction has also variabilities. So in majority of patients, again, it's within 1 centimeter. So knowing the location of this valve is very important because in superficial varicosities, it's because of failure of function of this valve that results in varicosities. So it's very important to identify this valve, and it penetrates actually the deep fascia and just at the mid calf and joins the popliteal vein. So there is also a very common vein which can result in a connection between the smaller or lesser subvenous vein with a greater subvenous vein, which leads to the greater subvenous connection. It's also clinically very important because sometimes this connection can connect these two systems normally, which they are separated, but this can connect the lesser subvenous vein with the greater subvenous vein, and may result in hemodynamic changes in one system, can result in varicosities into the other system, and it's very important to identify. We usually refer to it as Giacomin anastomosis. So the small subvenous vein also has some tributaries. So when we come to the other system is the perforator veins. These are veins which are connecting the superficial venous system to the deep system. So the function is to facilitate blood flow from the superficial venous system to the deep system. So they have their own valves which allow only unidirectional flow. And these perforators, actually, there are multiple along the lower extremity, and some say it may reach up hundreds, 150, may be located between the superficial and deep venous system. But the clinically important ones are very few, maybe 10 to 15 in the upper thigh, in the lower leg, and they can be identified with ultrasound examination. And most of these perforators are found along these veins and the lower leg as well, most in the medial calf and in the lower third of the leg. They actually previously they have their own names: cockade perforators, Boyd perforators, Hunterian perforators, and so on. But now that terminology has been replaced, and we refer to them with specific location from the heel or from the ankle. So they have a specific distance from the heel. So as I said, they connect the superficial venous system with the deep system, and so that they maintain an efficient return of blood. So understanding this intricate network of venous system and connecting pathways is very vital for understanding the pathophysiology as well. So that's where we'll come to. Some important things to consider, especially considering the greater saphenous vein, lower saphenous. There are some accompanying structures, especially in the greater saphenous vein. There is a saphenous nerve which supplies sensation to the medial aspect of the lower leg. It's a very important nerve for sensation of the medial aspect of the lower leg, and sometimes during surgery it may be injured. That's why the procedure, especially this striping or venous ablation, with especially thermal ablation procedures, only should be done above the knee, so that we can, because it's very close to the vein, and it can result in unnecessary injury to this nerve. Then the other structure which may be found in the which is closely associated with the lesser saphenous vein is also the sural nerve. So again, it becomes very close to this vein, just below the upper third or mid-calf region of the leg. So again, striping and thermal ablation should be done only just above the mid leg, just to avoid injury to this nerve as well. So coming to just talking about some physiology, again, this is very important to understand. Understanding the venous physiology is very important to understand how the blood flows back to the heart, and also the potential changes that can arise. So the venous return mechanism, actually in our body, the arterial system is pumped by the heart, but for the venous system, there is no single organ which returns. So there are a number of factors, including inspiration, increased blood volume, increased venous tone. Also, there is a cardiac suction effect, and the visa tergo, which is a push from behind. The arterial pulsation also assists somehow. But in the lower extremities, the most important components for return of blood flow to the heart is the calf muscle pump and venous valves. Competent venous valves are very important for venous return. This also requires a patent venous outflow in the deep veins as well, because the flow is from the superficial venous system to the perforators, then to the deep system. So the calf muscle pump and these venous valves are very important components. So let's see them individually. The calf muscle pump, what it causes is especially calf muscles in the lower leg. It compresses the deep veins, because especially during standing position, because of the hydrostatic pressure, the blood flow, the blood will accumulate in the lower extremity deep veins. So this will increase the pressure in the intravenous pressure. So what it does is, when there is a compression effect by the calf muscles, this will decrease the pressure and push the blood in the lower extremities forward towards the heart. And this also, during muscular relaxation, this also during this process, the valves also close to prevent backflow and reflux. And this will reduce the pressure in the lower extremity deep veins, and this will also facilitate the flow of blood from the superficial system to the deep system. So during compression, this will facilitate the blood flow forward. The other component is a valve system. So as you know, typical of venous system is they have valves. And these valves are actually very common and multiple in the lower extremities as compared to other veins in the other parts of the body. This is a kind of adaptive mechanism for lower extremity, especially for us humans. When we are standing, the venous return has some challenge. That's because of the gravitational effect. So there are multiple valves in the lower extremity, in the deep veins, as well as the superficial, especially the superficial venous system. When we see the greater subvenous vein, for example, it has more than 6 up to 10 valves. The lesser subvenous also similar to that, and the deep femoral vein can also have multiple valves, up to 5, 6 valves are present. And when we see higher up, for example, the common femoral vein has not more than 1 or 2 valves, and the iliac vein is said to have no valves, and IBC has no valves. So you can see that these venous valves have important role for venous return, because especially in the lower extremities, there are numerous valves are present. So typically these are, as you can see in the picture, they are bicuspid valves only allowing unidirectional flow or single direction. So during squeezing or compression or muscular contraction, these valves will open up and allow only forward blood flow. And during the reflux, there is what we call a physiological reflux, which is very for a brief period. This allows for the valve cusps to co-opt and close and prevent further reflux of blood and decrease the retrograde flow. So this is the supravalvular pressure is what allows these venous cusps to venous valves to close and prevent reflux. So as I said earlier, during standing position, there is a hydrostatic pressure. The lower extremities have to or need to overcome the effect of gravity. So this is a unique thing for lower extremity veins. They have to work against the gravity because in that column of blood vessel or the vein, there is blood that exerts pressure, sometimes reaching up to 90 millimeters of mercury. Because it depends on the distance from the heart level to the lower extremity. So this is actually a force that opposes the venous return. And the calf muscle pump and the venous valves are the mechanisms that work together to counteract this effect. So when you are standing, there is hydrostatic pressure, and when you start to walk, this pressure will be relieved because of muscular pump, decrease the pressure, and with this will facilitate the blood return from superficial, deep system, superficial to the perforators and to the deep system, and blood will be pumped back to the heart. So when we come to, and understanding this basic anatomy and physiology is very important to understand the pathophysiology of how these varicose veins occur. So as you can guess, the most important factor in the development of this varicose veins is valve dysfunction. It's very rare that we see pump failure in patients who have muscular dystrophy and so on. They may have problem with pump. However, that's not a very common condition. It's a major factor is valve dysfunction. So these incompetent valves allow reflux. They normally prevent reflux or backflow of blood when this calf muscle compresses. But when these valves, as you can see in the picture, normal valves work like this, but abnormal dysfunctional valves allow or fallback of blood. And this will result in what you call recirculation phenomena during upright position. So there is a reflux, for example, when you see here, maybe saphenofemoral junction here. So there is, when there is a pump in the deep venous system, it will reflux into the superficial venous system. And if there are distally, there may be competent deep, perforator veins, which may return back to the deep venous system. So we call this phenomena recirculation phenomena. So this is a reflux site, and there is this one is the re-entry site. So understanding this venous hemodynamics in the pathophysiology of varicose veins is very important for the management. So presence of varicosis actually depends how efficiently the venous drainage is. So there is a drained system as well as poorly drained system. So in drained system, that means distally when there are good perforators, functional perforators, this reflux can be adequately, efficiently, maybe returned, and patients may not be that much symptomatic. They may not show the visible symptoms of varicose and so on. But in a patients who have a poorly drained system, this will accumulate, and there may be multiple perforators which may also be leaking, and they may have a significant varicosity and symptoms, lower leg swelling, and so on. So understanding this is also very important. So the whole, not only the venous anatomy, but its function, its hemodynamics, knowing its hemodynamics is very important for understanding this problem. So when this system is overwhelmed, the recirculation overloads the superficial veins. This will result in pulling of blood in the superficial venous system, including the truncal veins, the greater subvenous vein, lesser subvenous vein. Its tributaries will dilate because of increased pressure to this system. With each muscle pump, so it's not efficiently returning back to the heart, but this will transmit the pressure to the external or superficial venous system. So understanding reflux locations and re-entry points are also very important in the treatment decision. So when this becomes a sustained problem and becomes a chronic one, and venous return is not efficiently returning back, this is what we call a chronic condition, chronic venous insufficiency. So the venous system is not adequately returning it back to the heart. So this is because of one, as I said, the hydrostatic pressure. When you are standing, it's not efficiently returning. Also, it's also the dynamic pressure. Also, this dynamic pressure means the compression of the muscles during walking or contraction of these muscles is normally should be returning it back, but it is contributing to the pathophysiology. So this is what we call a chronic venous insufficiency or build-up of venous hypertension. So this sustained venous hypertension in the lower extremity is what we call a chronic venous insufficiency. So this is the pathophysiology of varicose veins, and varicose veins are just a manifestation of this problem, this venous insufficiency. They are not by themselves a disease, but they occur because of this venous hypertension resulting in visible varicosities. It doesn't only result in this visible superficial vein dilation. It can also lead to other consequences like venous stasis ulcers. These are because of a capillary. These capillaries also, the microcirculation is also actually affected of the skin. Can also be affected. This pressure can also be transmitted to the smaller veins as well, resulting in telangiectasias, reticular veins, and so on. It can also contribute to dysfunction at the capillary level. This will result in damage to the capillaries, resulting in protein leakage. RBCs, inflammatory cells, and so on will leak. This typically in the pathophysiology, these ulcers, these proteins accumulate around the capillaries and impairing nutrient exchange. Will result in a nutrient exchange will be affected, and the skin becomes local hypoxemia will result, and decreased nutrient and essential supply is impaired to the skin. This will result in ulceration to the skin. The skin can break down, and there are also other factors which are involved, like endothelial cell activation or dysfunction, because there are also inflammatory mediators, cytokines, also escaping to the extracellular matrix. This will result in activation of inflammatory cells. Extracellular matrix will accumulate there and will result in skin thickening. Also, the pigmentation, which is commonly seen in these patients because of the RBCs, the hemoglobin component, can result in pigmentation effect on the skin as well. So this is, in fact, the final stage of this chronic venous insufficiency, chronic stasis ulcer. So this is very important, again, to understand. This is also very important to understand because there is an underlying dysfunction. Unless you correct that, the wound will not heal. The nutrient exchange to that area for the wound to undergo its normal healing process will be affected. So unless you correct the underlying problem, the wound will not heal. So that is very important to understand the management of these patients. So this is, as I said, there is risk factors which contribute to venous insufficiency. There are cellular and microscopic or molecular changes which also occur. Which will result in not only functional, this functional change can also lead to morphologic changes in the skin as well as the veins. And finally, this is what we call a chronic venous insufficiency. So coming to the clinical manifestation of the disease. So the visible manifestations are actually varicose veins, spider veins. This is the visible manifestation, but patients also complain in advanced diseases. Patients may have also edema because of fluid accumulation, fluid escaping to the extracellular space, heaviness because of edema, worms, fatigue, pain, and typically these patients complain more as the day progresses and when they are standing for a long period of time, and they typically have symptom relief. That's how you differentiate it from other causes of edema, with compression, stocking, leg elevation, bed rest also relieves their symptoms. As I said earlier, there are secondary changes like skin pigmentation, brown edema, and venous stasis ulcer. These are also some of the manifestations that we see in these patients. So this brown edema is because of, as I said, there is protein leakage and there is proteinaceous deposits around the capillaries as well as in the subdermal area, which can result in also atrophy of the underlying subcutaneous fat. So typically it will result in thickened skin and discolored or pigmented skin. So it can also lead to other complications like thrombophlebitis. This is inflammation of the superficial veins, and they may be inflamed. They may appear tender and also superficially visible redness along these veins. They may be also swollen, and they may be at times quite painful. And the patient may also present initially with this complication. This thrombophlebitis sometimes can also, the thrombus can also, especially if it's very close to the junctions with the deep venous system, this thrombosis can also extend or sometimes break loose, and it can result in or extension of this thrombus into the deep veins and resulting in thromboembolic phenomena. So that is the most severe complication which can occur. Again, as I said, with similar mechanism, this thrombosis in the superficial system, especially if it's very close to the deep veins, it can extend into the deep venous system, resulting in fatal complications like pulmonary thromboembolism. Other consequences of chronic venous insufficiency, skin ulcerations, pigmentations, and skin changes are also some of the complications. And sometimes also these patients are typically, especially male patients, they complain of itching in the lower extremities, and often when they are itching, they may traumatize these very superficial veins, telangiectatic veins, and sometimes it may bleed massively, and they can come also on emergency basis. The other presentation is eczema. This is also a kind of skin lesion, which is weeping with some discharge and painful discharge, and some crustaceans on the overlying skin, which may also be a prelude for ulceration. So again, this is because of some allergic reaction, because of the components in the which are escaping into the extracellular matrix, like the hemoglobin. Can result in ischemia. These are some of the complications that we often see in these patients. So as you can see, it's just beyond just an anesthetic concern or a cosmetic concern. It can lead to these severe complications, and at times, or rarely, limb-threatening. Sometimes these venous ulcers can result in superinfection again. This may extend into the deep tissues, and especially if it's neglected, and if patients are not seeking early treatment, the infection can also extend into the bone. We have seen patients also losing their limbs because of this problem. So it can also be sometimes limb threatening. So so it starts with spider veins, as you can see in the picture, or superficial varicose, what we call very small veins, telangiectatic veins, or spider veins, and it may progressively increase in size. When it reaches more than 3 millimeters, it's visible from a distance, and it's what we call varicose veins. And if the venous insufficiency is significant, and impeding significantly venous return, it can result in leg edema and further skin change, and the final stage is ulceration. So when we come to the clinical evaluation of these patients, clinical evaluation is very important. It provides essential information to establish the etiology of venous insufficiency, also see the severity of the disease as well. And we can also judge the patient, how it has impacted the patient's quality of life. That's also very important. And it also helps us to guide our treatment decisions, and also to monitor the patient's treatment outcomes. So clinical exam typically starts with medical history taking. A focused history includes the location and duration of symptoms, the discomfort, the degree of discomfort. Some patients mainly complain of itching, others complain of an aching type of pain, or burning type of pain, or heaviness. They often show you their visible veins, telangiectatic veins, or varicose veins. And sometimes you may see skin changes, also pigmentations, and patients may also be, this may be also the primary complaints of these patients. Skin pigmentations and visible veins may be primary complaints. And you have to also ask if they have any previous evaluations of treatments, and also pregnancy status. Typically, pregnancy, as we have said, we can say it's a physiologic type of varicose may be seen because of those changes associated with pregnancy. And typically, in other conditions, this venous insufficiency or varicose tend to progress, but in pregnancy, they tend to have some remission because of when they're post-delivery, when they have relief of this predisposing factors, the compression effect and increased volume and hormonal effects subsides with perpurum, they tend to resolve. So this is one of the conditions that we don't intervene during pregnancy, and we can just manage these patients with conservative managements. So coming to the physical examination, we see this obvious superficial varicosities, edema. There may be ankle flare. These are again smaller veins around the ankle. We call that corona phleotatica. Skin changes, dermatitis, eczema, lipodermatosclerosis, atrophy of the skin, thickening of the skin, and ulcerations. These are typical presentation in these patients. Also, seeing how the pattern of this varicosity is also very important. It can also help you to judge where the problem is, especially when you see varicosities along the medial thigh. You can suspect it may be a problem in the greater subvenous vein. The anterior thigh may be related with accessory veins, and sometimes if you see varicosities on the lateral aspect of the lower leg, it may be related with a lesser subvenous vein, and sometimes you may see a lateral what you call a lateral marginal vein visible dilate, which is unusual, and it may be related with congenital problems like Klippel Trauner syndrome. And on physical examination, you may palpate for tenderness, induration, pitting, edema. And there are, in the past, we depend on clinical evaluations to identify the location of these refluxes. There are named tests. Now they have only historical significance. I'm not going to talk about them because they are completely replaced by imaging modality with Doppler ultrasound. They have only historical importance, but these days we don't do these tests because they are cumbersome, they are uncomfortable for patients, and they are also time-taking. But this, I hope you remember them: Trendelenburg test, Pertus test, multiple tourniquet test, so on and so on. So with this test also, you can do, especially when ultrasound is not easily accessible, you can identify the location of these reflux sites, and you can identify where the problem is. And the other very important thing is photographic documentation is also a very good habit in your clinical evaluation, because you can document visibly the extent of varicose veins. Also, you can monitor the change over time, and you can also assess the treatment outcome with photographic documentation as well. Next up is with diagnostic modalities. So the first line, or the gold standard for evaluating varicose veins, is Doppler ultrasound, Doppler duplex ultrasound. It's very important for diagnosis. It's because it's non-invasive, easily available investigative modality. It's very important for diagnosis. We can specifically identify where the reflux site is, where the entry site is. It can give you a lot of information with regard to the venous hemodynamics as well, studying the anatomy of these veins, as well as the hemodynamics as well. Also, in treatment planning, if you identify the lesion where the problem is, you can plan where you are going to intervene. Also in guiding treatment, especially with endovenous procedures or sclerotherapy, ultrasound is a very useful guide for during your treatment as well. In fact, it's very essential for placing your access site, or putting your probes and fibers in the case of laser treatment. In sclerotherapy also, you can use ultrasound guidance to put your needle in this case. So ultrasound has become very essential. In fact, it's part of your physical examination. Even for surgery, it's a good habit to for the person who is going to intervene to do his own ultrasound and know the anatomy, the course of these veins, and so on. As you can see, Doppler duplex ultrasound, it has two modes. That means with the B mode, you can study the anatomy, Typically, as I already told you earlier, subvenous vein, the real subvenous vein is within its own compartment. So there is a superficial fascia, and this is a deep muscular fascia. So it's bounded by this, or along its the whole length. So any vein outside of this is not regarded as greater subvenous vein. Of course, there are some anomalies which can occur absent or duplicated, and so on. Anomalies can also occur in this greater subvenous vein. So typically, this is what we call the subvenous eye or the Egyptian eye, two straight eyebrows and hypoechoic circular structure. So that is during your evaluation, you have to study the entire anatomy throughout its course. It's also connection with the deep vein at the saphenofemoral junction should be mapped. And the other thing is the hemodynamic assessment. That is with the Doppler component. You can study where the reflux is. Typically, we have a threshold value for the reflux. For the superficial veins, when the reflux based on timing, we can assess also the severity of the reflux. And typically, when it's more than 500 or greater milliseconds, it's we say that it's reflux. And perforated reflux is typically greater than 350 milliseconds, or vein diameter greater than 3.5 millimeter. So the indications are if there is suspected varicose veins, or the appropriate evaluation, assessment of recurrent veins, and evaluation of its complications. So the other thing is probably sometimes the imaging report that we often get when we send these patients for evaluation, for ultrasound evaluation, is inadequate reporting and documentation regarding the entire problem. So our radiology or sonographer colleagues should use a standardized evaluation or documentation and reporting method. So a typical evaluation includes a detailed report on the presence and location of incompetent veins, the severity, and it should be reported both in a schematic, preferably with a schematic and some texts as well, and documenting for each of the veins at intervals, their diameter, and also if it's reflexive, it should be reported as well. This is very important for the decision making. It's very important, in fact, for our decision making. And if it's possible, the interventionalist also should be able to also perform this evaluation so that it will guide him for the treatment. There are very rarely we proceed with other imaging modalities like CT or MR venography. This is specially indicated if you are suspecting other problems like congenital anomalies and so on, or if there is a deep vein obstruction, especially in the deep pelvic veins like May-Turner syndrome, which is compression of the iliac veins and so on, or IVC compression because of several things. If you are suspecting this thing, this additional test may be indicated. So after your clinical evaluation, we can classify the disease. There are commonly used classification methods. This structured and standardized approach for assessment is very important, so that you can communicate with other colleagues, and also it can guide the treatment as well. So we have this CAP classification commonly used. It not only classifies based on the clinical finding, but also the etiology, the anatomy, and the pathophysiology classification. So C is clinical presentation. It has starting from symptomatic to C6, which is patients who are having active ulcer. So it has also subcategories. Again, this is the simplified form. There is a very extended form of this CAP classification. So it's very important to help guide treatment and to facilitate communication. Other commonly used classification is, in fact, this one is, that one is subjective or qualitative. This one is quantitatively assessed, and you can score based on the symptoms. You can score the symptoms of pain, varicosities, edema, skin pigmentation, the inflammation in other clinical symptoms, and you can say these cumulative scores can help you to categorize them to mild, moderate, and severe disease, and it also helps for communication and guiding your treatment. Also to track the disease progression as well as treatment response as well, treatment outcome as well. So when we come to the treatment options, we have a range of treatment options, starting from very simple measures, conservative management, to the most advanced treatments like minimally invasive treatments. So coming to the conservative management, first line is, in fact, the initial management for almost all patients is compression stocking. It's very important. Compression stocking, it helps in relieving the symptoms and decrease the progression of patient symptom, progression of the disease, and it should be offered for almost all patients with varicose vein, especially also for venous ulcer diseases, because surgical intervention during in a patient who have ulcer causes another additional trauma. So this initial conservative management is first line, the first line management in patients with venous ulcers with complication, as well as for patients who are symptomatic. And it also helps you to assess the response to this conservative management, and it also helps to evaluate whether the patients will respond well with your interventions as well. There are other adjuvants that we give. Also, there are drugs like venotonic drugs or like diazepine and aspirin and pentoxifilin. This especially pentoxifilin is helpful in venous ulcer healing, and sometimes. So the problem is these drugs may not be available, and actually these drugs by themselves are not they are not helpful. We have to give them in addition to the compressive stocking or other management. So by themselves are not that much helpful. So when you are ordering these things, some of your patients may prefer just oral treatment, and they may hope for a resolution of their symptoms. But these treatments alone are not usually helpful. So you have to use compression stocking as well. And some of the advice that you can give for this patient is maintaining healthy weight, exercise, their diet, also elevating their legs. Sometimes you use also compression stockings when they are standing for a long period of time. These are some of the lifestyle modifications that you can advise. So with this conservative management, you can manage most of these patients and delay the progression of the disease. But in advanced diseases, this conservative management alone may not cure the disease. So you have to plan some kind of intervention, especially in advanced diseases. The other treatment option is minimally invasive options like endovenous thermal ablation. This is using a thermal method endovenously, delivering a heat and closing these veins from inside. And the other is chemical ablation, again, similar to that, which uses chemical irritants to damage the inside of the veins and facilitate their closure. The other commonly done procedure is surgical interventions like vein striping and staph avulsions. There are also some lesser invasive methods of this surgical intervention, like perforator endoscopic perforator ligation and also saphenous options. So let's go through some of these techniques. So with regard to compression therapy, as I said, this is a fundamental management option in patients for varicose veins, and it should be offered for almost all patients as initial management. So how it works, it improves the venous hemodynamics by applying that compression. It reduces symptoms and complications, and it facilitates a venous return and prevents reflux from if there are some perforators, and it also helps for the calf muscle pump and improves the venous return. Also, it also has been shown to improve the microcirculation, so it's associated also with the increased venous ulcer healing, and it has also said to have some anti-inflammatory. So it has a number of effects through which so it's the most effective treatment. In fact, the most effective non-surgical treatment or non-interventional treatment is compression therapy. So there are several types of compression therapies. The ones that we are using commonly are for varicose veins is these graduated compression stockings. These are they have classes and they apply a certain pressure. So for lower pressures starting from 15 to 20 millimeter of mercury, these are kind of prophylactics that we use for prophylaxis of PVT for patients who are going to have a long flight or bedridden patients. We can use that one. But for varicose veins, we have to use some compressions starting from class 2, that is starting from 15 millimeter of mercury up to 25 class 2, and class 3 up to 30 millimeter. So for varicose vein, we usually use these compression grades starting from 25 to 40. That is so there are compression stockings also above 40 millimeter of mercury that's used for other like lymphedema and other problems. But for varicose veins, we use compression stockings starting from 15 or 20 millimeter of mercury up to 40 millimeter of mercury, depending on the extent of edema and disease severity. So as you can see in this picture, the maximum pressure should be around the ankle. This is why they are graduated, so that it will facilitate the flow from distal to proximal. So the compression progressively decrease in its strength or in its grade of compression as it proceeds proximal. So the maximum pressure is around, the maximum compression is around the ankle. There are also other types of compression band-aids. These are either medicated, especially this for venous ulcers. We sometimes also use medicated compression stockings, compression band-aids. They have some medications which soothe the skin, facilitates the wound healing. Commonly used one is called Unabut, which is a kind of you just wrap it around the leg, and when it dries like a cast, it applies certain compression. Again, it's medicated and it's said to facilitate wound healing. There are also other intermittent pneumatic compressions and so on. So this is very important to understand when you are especially ordering your compression. You have to make sure that it's proper size, proper fit, proper compression grade. That's very important. And also the length is also sometimes very important, especially in diffuse or involvement of the superficial varicosis. You have to use sometimes above knee compression stockings, and for some patients below knee problems, you may use below knee compression stockings. So these are very important factors when you are prescribing this compression therapy. So the indication, it can be used as a preventive measure, as I have said, in patients who have at risk of DVT. You can use even for some patients as well, their occupation that demands long standing. We advise them to wear this prophylactic type of compression stockings. They are available over the counter, but this graded compressions, graduated compressions may need prescription, but you can buy those compressions which are low grade or mild compressions up to 15 or 20 millimeter of mercury that you can obtain it from the pharmacy, and you can also use it, especially if you are standing for a long period of time. Those things can improve actually the fatigue and the discomfort that you feel, which you sometimes ascribe it as tiredness or aging. It may be because of it may be related with this problem a problem in venous insufficiency. So it can also be used as a treatment, as I have described, management of venous ulcer, superficial thrombophlebitis. You can use it, and also for edema reduction. These are some of the indications. Second one is sclerotherapy. This is, again, it can be regarded as a non-invasive treatment. So the idea is you inject, this involves some chemical agents, sclerosants, into the affected veins, and this will lead to their collapse and scarring, and they eventually disappear. So it can be used, typically it's used for smaller veins like telangiectasias or reticular veins, but these days they are also using it for larger veins, even for truncal varicosities like saphenous veins as well. You know, modern advances, they have delivery devices for larger varicosities, and they also are giving for varicosities involving the greater saphenous vein, lesser saphenous vein. So their mechanism of action is actually damage to the endothelium, venous endothelium, causing inflammation. This will induce thrombosis, and eventually they will collapse. And finally, they will fibrose and resorb it by the body. And typically for these telangiectasias, they are very effective. They are very effective. Sometimes the side effect is some patients may have allergies, so you have to be careful about it. And some of their drawbacks maybe is they may cause some pigmentation, which may stay for months or years. And that may be also some of the drawbacks. But however, they are also very effective in the management of these varicosities. So typical sclerosants we use is estase, sodium tetradecyl sulfate, and polydocanol. Other these hypertonic saline and glycine are rarely used. So these are commercially available with different brands and different concentrations. So it depends on the amount that you are giving, depends on the extent of varicosity. And the technique is you can give the liquid form, or you can also, if you have especially a larger vein, and if you want to use a small volume, you can increase its volume by mixing it with air. We call it a Tazari method, where you mix 1 portion of the sclerosant with 4 portions of air. It can be room air, and you mix it like shown in this picture, and you can make a foam. That's what is called foam sclerotherapy. So it increases the contact time. It's effective. You can use it for bigger varicose veins even, and for larger veins if you are going to use, because sometimes there is a dose limitation and you may not give large doses. So you can increase the volume and you can use it for larger varicose veins with this technique, foam sclerotherapy. So typically you just a very simple office procedure. You cleanse the area. Sometimes local anesthesia may be used, and you inject the sclerosant. Sometimes you may use ultrasound guidance to put, and you use very fine sutures like needles, butterfly needle, and you can insert directly, put access these veins and inject serially. You may need to have multiple injections, and also multiple sessions may be also required in these patients, because you may be limited by the dose, and patients may require 2-3 sessions to completely collapse all these veins, especially for patients who have a very extensive telangiectasis or varicosities. So post-sclerotherapy, you may apply pressure, compression stocking for a few weeks, and this also helps to resolve the residual varicosities as well. Next is venous stripping. This is a very popular procedure among the general surgeons, probably commonly done also by most people. Venous stripping, it's a 100-year-old surgery. It's introduced by Babcock. He introduced a metal Babcock stripper, which has a stripper at its head. It's really connected by a flexible metal tool and helps to stripe the vein from inside out. So now these days this procedure has been replaced most of by less invasive method, because it's said to be the most invasive procedure for varicose veins, and in the other parts of the world they have replaced it with less invasive methods. So some of very important considerations when you are doing, especially for general surgeons, anatomic knowledge is very essential. Identifying the greater saphenous vein, lesser saphenous vein, its junction, precise identification is very important. Sometimes you may mistake it for accessory veins. Sometimes also we have seen injuries to the deep vein as well as the femoral artery as well. So anatomic knowledge is very important. That anatomy, its saphenous compartment is a useful guide that will help you and guide you to that area. So typically that area, it has tributaries, accessory veins and other veins as well as superficial veins from epigastric vein, circumflex iliac, and pudendal. This typically at its junction, 3 to 5 veins may join the greater saphenous vein before its junction, and ligating those veins is very important. And in the older books, it suggests us to dissect up to the deep vein, and but we don't encourage that because it will result in injury to the deep vein, and it causes injury, and also further dissection also contributes to recurrence, because neovascularization, this dissection around that area, it will result in neovascularization later on. So so limit your exposure, limit your dissection to that area, and it's just enough to ligate just as it enters or penetrates the deep fascia to join the subfemoral junction. We call that the fossa ovalis. It's oval area that you see a defect. So it's just enough to ligate over that area and do your striping from top to down. This is also one important thing. And the other thing is that you have to make sure that sometimes when you are putting your striper, it may also go into the deep venous system, especially when there are large perforated veins. So you have to be very careful of that as well. And also in the past, people used to strip the entire length of the greater saphenous vein, but that is no longer recommended. Just above knee striping is very important. The reason being, the saphenous nerve is very close as it exists the adductor hiatus, and it becomes very close to the saphenous vein below the greater saphenous vein below the knee. So just limit your striping just above the knee. Regarding the small saphenous vein, it's a bit challenging because precise identification of this saphenopopliteal junction may be challenging, and also there may be some risks associated with it. Again, so precise identification, especially if you are doing your own ultrasound, it's very helpful to identify precisely where the location is. In majority of the patients, typical junction area is as the skin crease transverse crease behind the knee. So you can use that as a guide. And you have to make sure that jaw communication when you are ligating it, and make sure that it's present or not, because that will also contribute for recurrence of this problem. And the other thing is careful of the nerves, because nerves are closely related. We are going to expose the saphenopopliteal junction. There are nerves. So it has been reported neurologic disabilities have been reported, motor or sensory nerves, because there are also some variations in the nerve, like a low-lying sciatic nerve or tibial nerve, and also the sural nerve. So you have to be careful. And these nerves may also look like a tendon and sometimes mislead you. So avoid potential injury to this area and aggressive dissection over this area. So it's very important to consider these things when you are doing striping. And again, for striping of the lesser saphenous vein, you have to always stripe it. Most often, just ligating as the saphenopopliteal junction is enough, because there is no significant tributaries which are joining the lesser saphenous vein. But sometimes we stripe it. So if you are striping it, just up to the mid-cap is enough. So, so as I said, this has now been replaced by less invasive methods, but it has role in modern practice as well, especially for very large varicosities, looking aneurysmal segments in JSV, excessive tortuosity. This also will make it very difficult to pass your endovenous ablation instrument. So in this case, also striping may be indicated. Suppurative if it's infected with thrombophlebitis and also infected veins. You don't want to live with thermal ablation, so you have to remove it. And lateral marginal vein is another developmental anomaly. This is also some of the indications where you do striping other than less invasive methods like endovenous ablation treatments. So the other one is the kind of less invasive surgical option is stab ablations or phlebectomies or microphlebectomies. These are also commonly done. They are effective in reducing symptoms, especially for cosmetic improvement. What you do is just a multiple small stabs, less than a millimeter stab, and you use a hook to remove these small varicosities. And they are also very effective in treating especially below-knee varicosities. The other option, the surgical option, is saphenous sparing operation. This is based on hemodynamic concepts, and it's not very popular, but it's especially for vascular surgeons, it's interesting because by all means, preserving the saphenous vein is greater saphenous vein is important, especially if patients might need it for later bypass for arterial occlusion and so on. So it's not popular, and it's also a bit complicated, I can say, because you need to have you need to identify these hemodynamic problems. A thorough understanding of hemodynamic problems is very important. So what you do is just you spare the truncal veins, saphenous veins, and you only treat the refluxing portions, and you preserve also the re-entry points, because they will depressurize the increased pressure in these segments and relieve the symptoms. It has been shown effective, and also it's also very appealing. Actually, I don't know the practicability, but it's very appealing also for surgeons to practice this thing. So the techniques include Chivas. This is introduced by a French surgeon, Franceschi, in the 80s, and he's the one who introduced these hemodynamic concepts, and it's very interesting that introduced this procedure. However, it's not commonly done, and some people try to also introduce it here, and we'll see how effective it is in our patients as well. So coming to these less invasive methods, endovenous thermal ablation. As I said, this is a least invasive approach in treatment of varicose veins, and you use a heat to destroy the inner veins, and it will result in collapse and closure. So typically we have two options: endovenous laser and radiofrequency. Typically both these procedures work in the same fashion because they produce heat, they result in destroyal of the venous lining and result in collapse. So we'll see in detail about laser ablation. This is a modern way of is widely practiced in the Western setting. It's minimally invasive procedure. Use laser light. So the basic principle is a machine. It has some atoms or molecules. We call them diodes. These diodes, when they are excited, typically with electrical energy, with their electrons, when they are excited, they emit photon. That's light. So what it typically does is it emits light in the infrared range. So this light is typically monochromatic. That means a single wavelength, and this light will be amplified, and when it's absorbed by the tissue, that will create a heat, and that heat helps to collapse these veins. So in this procedure, the laser fiber, the delivery device is which is connected to the machine, is a fiber that's connected with the machine. It will be inserted into the veins. These are very thin catheters, very small catheters that you can put it through a needle. And so the entire procedure, just you can finish it and close by just a needle prick. So they usually are performed under local anesthesia with minimal discomfort. Their advantage is short recovery, few complications, and there is a high success rate. Most reported outcomes say. So it's light amplification by stimulated emission. So it's just a light. So you have a fixed wavelength. They typically range from 810 to 1940. The newest generations are 1470 nanometer and 1940 nanometer. So they differ. They're fixed wavelengths. But you can adjust the energy. So it allows you, the machine allows you to adjust the energy, and you can adjust how much energy you are giving to a specific vein segment. So the newer generations are they absorb more. They are mainly absorbed by water. The previous ones are hemoglobin, the hem component in the blade, which is absorbing more of this light. But the newest ones are said to be very effective. You can use less energy because they are more absorbed by the water in the tissue, and they tend to collapse. And very important adjunct in this procedure is ultrasound guidance. So you need a real-time ultrasound to ensure this accurate fiber placement as well as your access. And it monitors the progress throughout the entire procedure. Ultrasound is very essential in this procedure. So essential equipment when you see is a laser machine. So you can select which wavelengths that you are selecting. Typically, the newest generation, as I said, are 1470 nanometer and 1940 nanometer, and they deliver specific wavelengths of this light in the infrared range. They are in the infrared range, and they generate heat. And depending on the machine type, you can adjust the frequency of this laser light, as well as you can the timing. These adjustments are possible in these machines. So you have ultrasound machine that is also very important to guide your laser, your access, and so on. Tumescent pump is another essential equipment that we use. This is important because during the procedure, you have to use tumescent fluid. That is, it has multiple functions. One is to compress the vein. It's mechanically compress the vein, and it will facilitate early closure, as well as it will keep the skin away from your laser fiber, because it's generating a high heat. It can damage the skin burn. So that's how it can serve as a heat sink. The other thing is it also serves as, especially in outpatient procedures, office procedures, it's also because this tumescent fluid helps for, it has also local anesthesia in it, and you can use it as local anesthesia. So you deliver that fluid through this machine. It's a pump that injects fluid, the tumescent fluid. The other very essential equipment is laser fibers. They also come in different types and so on. The other equipment are introducer needle, tumescent injection needle, and also this procedure is done with sterile procedure, and you need to have sterile drapes for the ultrasound probe as well, and local anesthesia. These are essential equipments and material that you need for this procedure. So the indications are again similar to that: symptomatic varicose veins, and patients also seeking minimal treatment, minimal invasive options, or if they want to quickly return to their daily activities. As you know, surgery is associated with pain, and patients may require some bed rest until the wound heals and so on. So this will completely change this requirement. So commonly treated, a greater saphenous pain, smaller saphenous pain, and some accessory tributaries can also be treated. Also perforators in some selected cases can be treated with laser, endovenous laser treatment. Again, it has some contraindication in DVT, and if there is significant arterial insufficiency in venous toxicity, because it may be technically difficult to insert these fibers. So basic steps are, again, preparing the patient, equipment, and needle access. Typically, the needle is accessed. Again, we have to ablate just above, just below the knee, up to this area, because again, it can result in injury to the nerves, and because the skin is very thin over this area, and it can result in burn to the skin. So it should be done just on the lower portion of the knee up to here. And the entire length of the saphenous vein can be ablated. So needle access is obtained with ultrasound guidance, and you insert your sheaths. Then laser fiber will be inserted through the sheaths. And very important critical step in this procedure is the laser tip, the laser fiber tip, because sometimes if you advance it into the deep vein, it can result in DVT. That's a severe complication, which is we normally refer to it as heat-induced thrombosis, and it can result in life-threatening complications. So you have to make sure that it's well below the junction. Typically, it should be up to 2 centimeters from the junction. So that's how you confirm with ultrasound your tip placement. And tumescent anesthesia then helps you to, again, for anesthesia and collapsing the vein. And then finally, you activate your laser. That's typical steps in the procedure. So post-procedure, patients can do their activity. We advise them to wear compression stocking for 1 to 2 weeks, but they can resume their normal activity in just a day. And it can be done in office procedure with this tumescent anesthesia. Again, as I said, skin burns and DVT are some of the complications which might occur. So again, to emphasize, it has less pain, bruising, less scarring, fast recovery, quick return to daily activities, and it's a number of advantages when compared to open surgeries. And the outcome is also very good, 90-95% long-term closure success, and recurrence is very low after this procedure. So coming to our EVLAT introduction here in Ethiopia. So endovenous ablation, as you might have heard, we have introduced for the first time here in Hawassa. and it brings actually an advanced minimally invasive treatment option for our local community. So this means patients no longer have to look for abroad for getting this treatment option. So this will create also it's not only just a significant development for Hawassa, but for we think that it's also a small step towards close to modernization of our healthcare system as well. And it's also an advanced patient care with minimally invasive options, and enhances local access to the state-of-the-art treatment. And I'm very much honored to play a role in this advancement, and because it's represented a step forward in making available this high quality treatment option for our patients, and by expanding this local access to this advanced treatment option, we can advance our treatment options, and it's also a model for bringing other treatment options, other advanced treatment options, and it's feasible. So we started it in a private setting. So I expect other private settings to follow suit as well, and advance our bringing advanced treatment options to Ethiopia in other vascular care as well. And of course, it has a lot of challenge because of it requires a machine, is expensive. The upfront costs is a significant investment, and also the costs for consumables per head is also significant, but still possible to achieve this service in our setting as well. So I'll just wrap up with a summary of my presentation. So varicose veins are a significant health issue, and recognizing the risk factors cause symptom helps in identifying, managing the disease very effectively. Understanding the pathophysiology is very important for your clinical decisions. And there is no single treatment that you have to know, because all these treatments are still pertinent and important, including starting from conservative management to these advanced procedures. And multimodality, personalized approach is recommended, and there is no single solution for all patients, and it should be individualized. And accessible minimally invasive treatment options for varicose vein can transform, especially for our patients, the outcome as well as healthcare standards in our country. So I wrap up my presentation here. Thank you all for your attention today. I hope the presentation provided you some valuable insights in varicose vein, understanding of varicose veins, as well as its management. I would like to open the floor now for any questions. Please feel free to ask any question. I'll do my best to provide answers and clarifications. Thank you.
Thank you very much, Dr. Dagim. That was a quite comprehensive and interesting session. So thank you once again for sharing your expertise on introducing endovenous laser ablation treatment in our country. So in order to save time, we're going to be sharing the quiz link now and also doing the Q&A simultaneously. Okay, can you see my screen, Doctor?
Yes, thank you.
So the first question is, one may think that in our setting, laser ablation therapy can be unaffordable considering our population income. So what is your point of view about setting up this treatment modality in terms of cost?
Yeah, so cost consideration is, I feel, also very important consideration in introducing this treatment option. So we can see it in different aspects. One is because of its advantage, early return to work, decrease pain, so that you can do your daily activities and so on. This is also some of indirect costs that you may save with a few extra few extra money. That's one thing. And the other thing is there are different different machines that you can, especially the most important cost is one is the machine, the upfront cost, and establishing this setup is quite maybe expensive for setting up this. After the initial investment, I hope the institutions will get a good return. But regarding on the cost directed to the patient is consumable costs per head. That's one of significant concern. The major cost is with regard to these fibers, leather fibers. They are a bit expensive for our setting, but in our setting here, we are using these laser fibers which can be reused. The company also produces these laser fibers which can be used for a few patients after processing. Like any other instrument, you can process it with recommended processing techniques, and you can reuse it for some patients. So I think this will significantly decrease the cost associated with the procedure. And I think we are introducing it's comparable to open procedures, and I think the cost is affordable for most patients, especially those who are seeking less invasive treatments, and again, those patients who are want to avoid, because I see some patients want to avoid the surgery because it's very, when you are explaining this procedure for patients that you are striping from inside, they feel very shocked. And some patients usually ask for less invasive methods like drugs and so on. So this is a good option for those group of patients. I think it will be applicable for a broad group of patients who are having these problems.
Okay, thank you very much, doctor. So the second question is there any association between varicose vein and hemorrhoids?
Okay, again, you can consider it the pathophysiology similar, increased pressure in the veins and expansion. But there is no direct relation, but often patients who are having, for example, when there is increased pressure in the venous systems, it may result in expansion of this veins, typically in patients, for example, in pregnant patients, which may increase the pelvic pressure. They may be predisposed for hemorrhoids. But unless patients are having other predisposing factors, these two things are not related, because the main pathophysiology in varicose veins is problem in the venous return, that is problem in the valves. And hemorrhoids, usually these are small veins in the pelvis, and it's usually associated with increased pressure in the pelvis. And so primarily there is no association, but you may see in some patients these problems together.
Thank you very much. The third question is, what is a spider vein, and is varicose vein associated with disc prolapse?
No association. I can say there is no association with disc prolapse.
Thank you. The fourth question is, would Doppler ultrasound help to do at stage 1 or at the spider vein stage?
Yeah, so spider veins, they are clinically important. They can occur in any part of the body. They may not be associated with significant symptoms, but most often patients complain of their appearance. They appear like a spider web, and they may have a cosmetic effect. That's the usual presentation patients come. But the most important thing from clinical aspect is they may indicate an underlying problem, venous insufficiency. So spider veins is an indication to do a Doppler ultrasound. You have to make sure that these patients are having a venous insufficiency, and if they have an incompetent valve in saphenous, because when there is incompetence in the saphenofemoral veins, these are a bit deeper in the subcutaneous tissue, and they require a large pressure to be distended, the bigger veins, and this may be spider veins, maybe initial presentation or initial manifestation of a deeper problem. So it's an indication to do a Doppler ultrasound.
Thank you very much. The fifth question reads, would Doppler ultrasound, my apologies. The fifth question reads, is there any difference between duplex and Doppler in sonographic studies?
Yeah, it's a duplex Doppler is usually referred as duplex Doppler ultrasound. Doppler indicating that you can also see the flow inside the veins. That is the main principle in Doppler. So you have also a duplex function, that is you can see the color. By seeing the color, you can see the flow pattern and so on. But a simple ultrasound, beam mode ultrasound, will only show you the anatomy of the veins, while duplex, which is a combination of both anatomy and this additional study, the flow study, is called Doppler duplex study.
Okay, thank you very much. The sixth question reads, in the absence of Doppler ultrasound in peripheral hospitals, are there any maneuvers to localize?
Yeah, I have said earlier, there are, in fact, in the past, people depend on these clinical tests to identify the site of reflux, like whether there is a deep vein occlusion, or incompetent valve as saphenofemoral junction, saphenopopliteal junction, or where the perforators are refluxing by doing multiple tourniquets. Again, it's very unlikely that you don't have the Doppler these days. It's widely available. But still, knowing this clinical test is still important. Again, you have to consider the time it takes, and also uncomfortable for the patient. But these tests can be done, and although they are not very sensitive, it can give you some idea.
Thank you very much. The seventh question was from one of our attendees. So that attendee had a venous stasis ulcer on the left part that affected their lower leg, and it left a hyperpigmented lesion and was deformed. So is there any chance this problem could be resolved later in the future? And what do you recommend as a prevention?
Yeah, definitely. This indicates an advanced disease with ulcer, pigmentation, skin thickening. Now the skin has become affected. So this is clinically C5 stage. It's a prelude for ulcer. So the next stage would be, which will result in ulcer formation, because the skin is becoming affected, its circulation, microcirculation is being affected. So that underlying problem has to be treated. So this patient definitely has chronic venous insufficiency that need to be managed. So the underlying problem either need to be managed. So the initial management is, again, I recommend initially to apply a compression stocking. That compression stocking is very helpful to decrease the symptoms, and it also helps for the skin to recover. Yeah, so definitely these things can be reversed. Unless they progress later on, they may result in some scar or permanent pigmentation. But if it's earlier stage, these cosmetic problems can also be reversed with proper management. So advice initially, so this compression stocking also prevent the progression of the disease. So until you get a definitive management, compression stocking is a must in this case.
Thank you. So before we proceed any further, I would like to remind everyone that we have approximately 71 responses so far, with no more than 3 minutes remaining. So please try to finalize your submissions. So the 8th question reads, is medicated stock can be ordered to everyone, or in which stage, and is it available in Ethiopia?
Yeah, typically this medicates, the one I said, Unabut, is medicated. It has zinc, aluminum, calamine lotion. These are some substances, some medications that facilitate wound healing. It helps to for the skin to recover and so on. This is most often not available when I am ordering. Some patients may get it from outside when they have some relatives abroad. They can send them. But the thing is, the advantage is you can apply it when you are ordering these compression stockings when patients are having wound. It's difficult to apply compression stocking. So this is helpful because it's changed weekly. So it's advantageous if patients, especially those who are having ulcer, if they can get this compression medicated cast like Unabut, it's advisable for patients who are having ulcer. For other patients, simple compression stocking is adequate. Graduated compression stocking.
Okay, thank you very much. So the next question, in a setup where there's no venous stripper, is saphenofemoral disconnection with multiple ligations enough?
Okay. So again, as I said earlier, it's just a single recommendation. It depends on the patient's presentation. So as I said in the hemodynamics, there may be a refluxing site. So the most important thing is treating the refluxing sites. A simple saphenofemoral, for example, a simple saphenofemoral reflux can be treated with just ligation at the saphenofemoral junction. You may not need to do the striping further. That's why knowing the anatomy, knowing in detail the hemodynamics is very important for your clinical decision where to intervene. So you can't just say this is adequate, this is not adequate. It depends on the patient's presentation in its so studying the entire hemodynamics in the lower extremity is very important for decision making.
Okay, thank you very much. So the last question reads, how to manage varicose vein when there is concomitant DVT? Before we proceed, I would also like to remind everyone that we're no longer accepting responses. So thank you. Please proceed, Dr. Dag.
Yeah, in patients, so initially patients with DVT, this is a deep venous thrombosis. So obviously, till it recanalizes, these patients may show some varicosis in the superficial veins. But in DVT, the initial management is actually managing the acute DVT and applying some conservative measures, like maybe medical therapies, to prevent progression of this DVT, and compression stocking may be helpful in these patients. So even if these patients are having varicosities, it's better to delay these patients until they show the symptoms are significant. So what I didn't talk about is in deep venous insufficiency, this is a bit complicated, and these patients, when the deep veins, the deep valves are incompetent, it's not like the superficial veins. You cannot just strip them out. So the management is a bit complicated, but the initial management is again compression stocking. Compression stocking is a cornerstone of management. These patients additionally may require, especially for patients who have advanced disease, a chronic ulcer, they may require a lifelong compression therapy. Because the surgical managements are a bit complicated, you have to reconstruct those valves, the deep vein valves, or replace them. Valvuloplasty or valve transplantation, and these are some of the procedures that can be done, and this is indicated for very advanced diseases. So definitely the initial management, if it's an acute DVT, you manage that. Patients with chronic DVT, they tend to recanalize, but with recanalization, these valves may be scarred and may not be functional. So obviously they may present with varicosities. So that's why studying the deep veins during your ultrasound scan, studying the deep vein is very important. And if it's a significant problem is from the deep veins, you have to manage them for some time with conservative management, definitely with compression stocking. That is very important.
Okay, thank you very much, Dr. Dagim. So you've managed to address all of the questions raised here in a comprehensive manner. So we can finally wrap up by attempting the quiz together. I'll shortly share my screen and we can go over it. Okay, can you see my screen?
Yes.
Okay, so this was initially supposed to be a main T presentation, but in order to save time, we'll just go over it here. So the first question is, which of the following is the primary pathophysiological mechanism underlying the development of varicose veins? A is increased arterial pressure, B is venous valve incompetence, C is vascular smooth muscle hypertrophy, D is endothelial injury and inflammation, and E is increased capillary permeability.
So shall I answer? Yeah.
Yes, please do.
So the pathophysiology mechanism is obviously it's not arterial pressure. There is no connection with that. Vascular smooth muscle hypertrophy is not also in the pathophysiology of venous insufficiency. Endothelial injury inflammation is not primary pathophysiology, and increased capillary permeability is also not related in the pathophysiological mechanism. So obviously it's venous valve incompetence, which predisposes for reflux into the superficial venous system and increasing the pressure. That is a primary pathophysiological mechanism.
Okay, thank you very much. The second question reads, which of the following is a contraindication to endovenous laser ablation treatment? So the first choice is presence of deep vein thrombosis. The second is small varicose veins measuring less than 3 millimeter in diameter. C is age over 60 years. D is mid-venous reflux. And E is history of endovenous laser ablation treatment on the contralateral leg.
Yeah, so presence of deep vein thrombosis is a contraindication. The others can be done, although technically difficult. Small varicose veins can also be ablated. Perforators can be also ablated. Age over 60, in fact, these patients may be a good candidate even because they may not tolerate the invasiveness of open surgery. So older patients may also be a good candidate because it's an office procedure. Mild venous reflux is also can be done with EVAL, and history of EVLAT is not a contraindication on the other contralateral limb.
Okay, thank you very much. The third question reads, during endovenous laser ablation treatment, which of the following describes the mechanism by which the procedure treats varicose veins? A is laser energy stimulates collagen production, promoting venous wall thickening. B is laser energy induces thermal damage, leading to vein collapse and fibrosis. C is laser energy increases blood flow, restoring venous valve function. D is laser energy directly dissolves the thrombus within the vein. And the last choice is laser energy target only the superficial veins, preserving deep veins.
Yeah, so as we have said, laser machine generates an infrared light. That's light when it's absorbed by the tissue, by the water in the tissues. It will generate heat. That heat will cause that causes a thermal damage, and this will endothelial injury will result in thrombosis, and the vein will collapse and finally will be resolved. So B is the answer.
Okay, thank you very much. So the last question is, a patient presents to the clinic for evaluation of a painful, swollen and erythematous varicose vein. Physical examination reveals a tender indurated vein with overlying skin changes. So what is the most likely diagnosis? The first choice is chronic venous insufficiency. B is superficial thrombophlebitis. C is deep vein thrombosis. D is cellulitis, and E is lymphedema.
Yeah, so a patient with painful, swollen erythematous veins, which are superficially located, this is inflammation or infection of the superficial veins. We call that any inflammation or infection, we call that thrombophlebitis. So specifically, this is a superficial thrombophlebitis.
Okay, thank you very much, Dr. Dagim. So we've addressed all of the questions raised here. So on behalf of Yetena Weg and everyone who has joined us for this session, I would like to extend our heartfelt gratitude to Dr. Dagim for sharing his expertise on endovenous laser ablation treatment and its introduction in Ethiopia. So Dr. Dagim is one of the pioneers of these transformative procedures in our country, and he has also given us invaluable insights into the diagnosis and management of varicose veins, as well as their potential impact on endovenous laser ablation treatment in improving patient outcomes. So I would like to extend our heartfelt gratitude. Thank you. And to everyone that has joined us, thank you. And we'll see you again next week.